So we're going to move to Dr. Sharifi. He's a good friend and used to be in Cleveland. He moved south. He's going to talk about my worst venous complication.
Well, good afternoon, ladies and gentlemen. Dr. Shishabur, Dr. Banerjee, and the organizing committee, thank you for the exceptional program that you have put together. Despite my efforts to find some form of conflict of interest, I still have not been able to get one for over the last 10 years. And I've been going to all these booths, but so far, no luck. Worst venous complication. At the outset, I have to tell you that in order to have a problem in the venous field, you have to go really out of your way to create that, because the venous field is a very, very forgiving field. The operator has to go and do a deliberate, conscious, repeated, determined effort to do something bad, and that's rare. Or the patient should be really very ill and has to have unique characteristics that you have to choose between two evils. Somebody who has had recent spinal surgery and now presents with phlegmasia cerulea dolens. Now, that PCD has a 70% chance of death or limb loss. And so you have to make a decision here. Or there must be some form of external, bizarre factors, as we will see. Now, this is one case. We had a 40-year-old Native American man, 140 kilograms, history of hypertension and diabetes. 5 months earlier, he had an unprovoked DVT, initially in the left lower extremity. For unclear reasons, in the other hospital, they placed an IVC Optis filter, and I couldn't figure out why, because there was no contraindication to anticoagulation. He was placed on anticoagulation with warfarin for 4 months, and during that time was doing well. Once the anticoagulation was stopped, he started having bilateral progressive lower extremity symptoms, edema, induration, pain, tenderness, erythema, and he was telling me his legs were twice as large. He also had some transient chest pain and dyspnea. A small PE was diagnosed in the subsegmental branch on the right side. And once we took him to the lab, his legs were really, really bad. As you can see, there is absolutely no flow in the femoral popliteal vein. The extent of disease extends into the iliac venous system. You can appreciate the IVC filter. This is the Optis. We are not known by the way, the placement of this kind of filter has drastically been reduced now. And you can see that the thrombus goes all the way to the IVC filter, and there is some flow barely through here. The identical picture, actually the mirror image on the left side. By the way, the patient is now in the prone position, and this is through popliteal access bilaterally. Almost identical. You can appreciate the size of the veins here. This is very important in the subsequent discussion that we'll have, and it shows the acute nature of the disease and the fact that the venous anatomy here has been intact. It's not a process of repeat venous insults. And obviously it extends to the IVC. So this was our approach. 2 8-French sheets were placed in the popliteal veins and 2 infusion catheters placed. This is after 48 hours of TPA. I usually limit my TPA administration to 24 hours, but this was very extensive, very obese man, and not much progress clinically. So after 48 hours, he's brought down. Only marginal improvement, if you would say, maybe a little brisker flow, but still the problem exists. Again, mirror image on the left side, marginal improvement, and the thrombus still persists. A little bit better here now, some flow through the filter. So what we did there, we had to do something, and keep on giving thrombolytic therapy here. So this is an 8-French, just a guide catheter. Tried to extract as much thrombus from the filter as possible. Then I placed this device, which is the cleaner device. There's no magic about it. It was just available at that time. I'm not saying this is better than the others you have, whatever you're comfortable with. But this produced some vibrations here. We did it a few times. administered a little bit more of TPA, and you can appreciate the flow is now much better, but still not the optimum that you are looking for in this man. And you can appreciate the stenosis here. Now, again, your perspective for physicians who want to embark in the venous field, the expectations are different than in the arterial field. For example, a 10%, 20% lesion in the venous field can be really significant, and sometimes it can actually look normal. But doing the IVUS imaging here, it did show a vein compression. On the other side, when the clot was a little bit better, now you don't need an IVUS for here. You can appreciate that this is a significant stenosis. On the arterial side, you may let go and say, well, this is not flow limiting, but don't use that word for the venous circulation. So we went ahead and stented both the lesion here and excellent flow here, and the lesion here. You can see dog boning. You rarely see that in the venous field, but if it does point out to significant stenosis. And the mirror image occurred here. Flow was reestablished. The patient had excellent outcome. Now you would say, well, where is the worst complication? So what happened here? Features to remember, this was bilateral progressive DVT involving the IVC filter, bilateral venous stenosis. We used a variety of modalities here. It was a prolonged treatment course and excellent results. So where was the complication? There was no complication here. But I wanted to use that to make a segue to the second patient that I don't have as much images because of one of those external and bizarre factors that went into effect. This patient was a 35-year-old woman, morbidly obese, BMI of 37, factor V Leiden, previous DVT about 5 years ago. She had gastric bypass surgery 3 weeks before and had developed a left femoral popliteal DVT postoperatively. She received an IVC filter because she was post-op and this anticoagulation was not started until the DVT progressed, and at that time, she was placed on Lovenox and warfarin. By the way, if you look at the ACCP guidelines, even the 2012 one, if somebody has even intracerebral hemorrhage, and if they are stable after 48 hours, you can go ahead with regular anticoagulation. So waiting for 5 days, putting a filter in somebody who has been stable because of surgery approximately a month before is not good quality care. She presented, despite being on therapeutic anticoagulation with moderate PE, despite the fact she had the filter and had the therapeutic INR. Her symptoms started getting worse. The progression of thrombus to the iliac vein, as I showed you, into the IVC and into the IVC filter, again, similar to the case you had before. So I had planned percutaneous endovenous intervention. I talked to her parents, sat down together, got consent, performed the venography, exactly similar findings, and I ordered an infusion catheter. At that time, I was stopped by the radiology senior nurse. She just said, no, we are not giving you the infusion catheter. And at that time, in that particular hospital, there was some concept about staff empowerment, shared leadership. All of these are good things. I mean, we have to listen to our colleagues as nurses. But this just went way beyond that. So the staff empowerment actually depowered the doctor. I mean, I was the captain of the ship, but they cited a policy from the past saying that TPA is contraindicated in surgical patients. Now, my pleading started there. I said, look at that guideline. That's for systemic thrombolysis. It's not for infusion, local infusion. Their argument is that the policy does not differentiate between systemic thrombolysis. It just says thrombolysis. So I called the chief of medicine, and the chief of medicine said that you're doing this in radiology. It's beyond my level of jurisdiction. So I called the radiologist chief, and then he said that, you are an interventional cardiologist, so we don't have power over you. So I called the chief medical officer, and then initially I called the surgeon. The surgeon was adamant, no, TPA should not be given to a TPA patient because it was his case, and he didn't want any bleeding. And unfortunately, the CMO that I called also sided with the surgeon. So I was really in tears in that session. So I had to abort the case, and the patient went on to the floor on heparin, and I wasn't allowed to progress. 8 hours later, she became acutely hypoxemic, developed pulseless electrical activity, and she died at age 35 years of age. Now, obviously, very important legal implications. I was the only one who was not cited in the lawsuit. It was settled at a huge sum, but there was a young life which could have been saved, and unfortunately, it was rigid adherence to some policies which were against, the common sense. So to summarize, in a major intervention-related venous complications, as I said, the venous bed is a forgiving bed. You should be very cautious when you have a very normal anatomy in a young patient who has had a hypercoagulable state, has had PE previously, has had a filter. These cases are dangerous. You should be very careful when dealing with these. This is as opposed to the elderly. They have a lot of recurrent insults, and there is a lot of friction. Those, usually nothing happens to those. The other set of patients are the older patients who are at high risk of bleeding. For example, phlegmasia cerulodolens happening in somebody who has had recent head trauma, recent surgery, intracerebral hemorrhage, and stroke. No matter what you do, there is a very, very high risk, and you usually have to document that very firmly and with careful discussion. And with that, I would end and just say no to clots. Thank you.
Any questions?
So the optes obviously is a problem. They're great to put in and then kind of a nightmare after that. Did you consider smashing it against the side of the cava, trying to extract it, trying to break it up and remove it in that first case?
Yeah, very good question, yes. This was about 5 months into it. So we were able to open it, and the patient came back at a later date, and we removed it. We do the smashing, and that's a technique well reported, but that's usually for chronic cases. Then you have caval retraction. You can see it. The actual filter has become contracted, and in those cases, you can pass through, put a stent, usually a wall stent, and that would take care of it.
I think some of the things you described in the second case are not unusual. I remember a case we had. It wasn't to that extent. I didn't have to call anybody to that level, but the patient was post-open heart surgery and came in with a massive PE. And there was concern about giving TPA, and we had a PERT. And, I was advocating catheter base. And my argument was exactly what you said. There was a lot of hesitation on the surgical team because obviously they had just done open heart surgery, but I think that we resolved it because of the team. So sometimes having a team, a couple other people supporting you, it is helpful in those situations. So it's not just you going against, let's say, a surgeon per se. You have other people in a team that can support you. I don't know. There's no good solution.
No, that's absolutely important. Now I'm an advocate by IVUS. If even the patient doesn't need it, just go ahead and do an IVUS to document it and get the opinions, the affirmative opinions of your colleagues, so you're not the only person there. Yeah.
Thank you very much, Dr. Sharifi.
Just a quick comment on this thing. Number one, what he mentioned about IVUS is completely correct, because we had cases where we wouldn't do that and think it looks completely normal, and when you go in with IVUS, you could see that it's obstructed. But there is another thing that you mentioned, is this shared responsibility thing, particularly for the newer physicians in the field. This is becoming a menace. It's good that everybody wants to participate and you want the team to play a part in doing that. But what actually happens is it's come to a stage where I've been hearing from my colleagues at different institutions that they feel that their medical management and their decisions are being interfered on in a negative way. So I think this is something that the seniors should step up and do something about, because from a group of 173 physicians that we did a survey, we received news from almost 66 physicians having complaints about this kind of behavior in their cath lab. And that's a very big number.
The sad thing is that the people who are making the decisions are not the people who are knowledgeable. They would say, okay, the vein looks okay. Why are you putting stents in? I mean, they don't even say, why are you putting stents? They go and start the disciplinary process saying that the vein has a normal appearance. And they have no knowledge that vein behavior is different than the arterial behavior.
Well, I mean, I think these are all good points. I think publishing that work, I think, is helpful, so we need some data out there. But thank you so much. Really appreciate it, Dr. Sharifi. I know you stepped in for Dr. Bianchi, so we really appreciate that.